Hello and welcome to this small discussion on pleural-based diseases. I'm Dr. Renoy and I'll be guiding you through the common pleural-based diseases which comes to your clinical practice, especially with the focus of how to actually present them and actually face them for an exam perspective. So, as you're aware that there are two layers of pleura being the covering of the lung, and that is the visceral as well as the parietal pleura. So based on what accumulates inside or between these two layers of the pleura, you will have these definitions. That means if there is a serous fluid that is actually accumulated, it is a pleural effusion. If there is air getting accumulated, it's called as a pneumothorax. If air and fluid gets accumulated, it is called as hydropneumothorax. And if pus gets reaccumulated, it's called as an empyema. And whereas blood or chyle, it is subsequently called as hemothorax or chylothorax. So let's discuss how to approach a pleural-based disease. For undergraduates, the maximum stress is to be given on pleural effusions as well as pneumothorax because they are the routine cases that they would see in clinical practice as well as for the exam. Let's look at the historical perspective of this. One of the most important presentations for pleural effusion is a pleuritic chest pain. So what is a pleuritic chest pain? A pleuritic chest pain is usually one which is localized, which is of stabbing nature, and which is actually often aggravated by a cough or a deep inspiration or a breath. However, this can be actually relieved when the patient actually lies on that same side where there is an affection with the pleural fluid accumulation. This is because there is decreased friction between the two pleural layers when the patient lies on that particular side. These patients also can develop a slowly progressive dyspnea and a dry cough. Fever can be an accompanying feature, especially with exudative pleural effusions like tuberculosis as well as even bacterial pleural effusions for that matter. However, pneumothorax is where the air is getting accumulated, and usually the symptoms are of sudden in onset, and the progression of the dyspnea is usually rapid. These patients can go into acute respiratory failure, and one of the important clinical and general examination findings would be that patients can have cyanosis and other features of acute respiratory failure. Whenever you find there is significant tachycardia and hypertension in a patient with suspected pneumothorax, you should be thinking of a dire emergency, that is a tension pneumothorax, and accordingly work up and act rapidly on such a patient. So let's now look at the respiratory system examination findings. One of the most important inspectory findings is to demonstrate trail sign. Now, what is trail sign? Now, it's very clear from this particular picture that the right-sided sternocleidomastoid, both heads, that is the sternal head as well as the clavicular head, is actually prominent. And you can see that the clavicle is also shifted to the same side where the prominence is actually maximum seen. Now, why does this prominence occur? This is because the pretracheal fascia that actually covers the sternocleidomastoids actually becomes laxed because the trachea is getting shifted to that particular sides, and thereby it actually becomes more prominent. So where is the effusion when there is a tracheal shift to the right side? It's obvious that the pleural effusion or a pneumothorax causes a pushing phenomenon of the mediastinum. So the effusion is on the left side, which usually pushes the trachea to the opposite side. So we've already discussed that the pleural effusion or pneumothorax can cause a mediastinal shift to the opposite side. So one of the other inspectory findings that is usually well appreciated is a shift of the apical impulse. The apical impulse can be shifted to the opposite side according to the site of the pleural effusion, and sometimes in some cases, if there are large pleural effusion or even a pneumothorax, it can be obliterated on the left side. Another important inspectory findings is to actually compare the chest and look for its symmetry. To add to this particular point, I think the best position to actually examine the respiratory system is actually sitting position, probably on a stool with the hands on the time. So when you do that and assess the chest symmetry, in most of the cases, especially with mild or moderate pleural effusions, the chest symmetry might be equal. But in some cases where there is a massive pleural effusion, there might be an increase in the size of that particular hemithorax, which is appreciable on inspection. Similarly, the chest movements are actually decreased on the side of the effusion, both in pleural effusion as well as in pneumothorax. It is important to confirm the inspectory findings by palpation. And one of the important things to do in respiratory system examination is to confirm the position of the trachea. How do we do this? There are two ways in which we can do this. The first is a screening method as mentioned in the picture 1, where you keep two fingers in the medial end of the clavicle and then go from the top area and come down till the sternal notch. So you get a subjective feeling of if the trachea is actually deviated to one side. This can be confirmed by the insinuation method, wherein which you actually go on either side, that is side between the sternocleidomastoid as well as the trachea, and see whether you find any kind of a resistance to insinuation of your finger. Where you find the resistance, it is to that area or that side where the trachea is actually shifted. You will find a little bit of easy give way in the opposite side. So this is the insinuation method that I actually mentioned in the previous slide, where you actually go with your finger between the sternocleidomastoid as well as the trachea and look for any resistance. So again, I would like to press on this particular point because students make this mistake always by only doing the screening method and not doing the insinuation method. It is to the area where you find a little bit of resistance to insinuate. It is to that area where, or that side where the trachea is actually shifted. Let's look at all the palpatory findings of pleural effusion and pneumothorax once again. The trachea can be shifted to either side based on where the effusion is. Obviously, it's a pushing phenomenon. Similarly, apical impulse, because the mediastinum is actually shifted, it can be pushed to the either side. The chest movements are reduced both in case of pleural effusion as well as pneumothorax, and this can actually be confirmed by examining for the movements as depicted in this picture below. Okay, and at the same time, the hemithorax measurement that we do, because most of the measurements are actually done during palpation, you will understand that there is a slight increase in the hemithorax measurement, especially in cases of massive pleural effusions and significant pneumothorax. Another thing that we all do is actually to check for the tactile vocal fronitis as depicted in this particular picture, where you ask the patient to say 1 or 99 and check if it is actually normal, increased or decreased. In this scenario, when there is a pleural effusion or pneumothorax, you find the tactile vocal fronitis to be decreased. Before we go into the percussion findings of a patient with a pleural effusion or pneumothorax, let's look at the cardinal rules of percussion. Now, for a right-handed individual, the pleximeter finger is a left middle finger, which is usually firmly applied to the chest. Now, the firm factor is important because you should avoid air pockets between the finger as well as the chest wall. The other fingers needs to be raised, and only the middle finger needs to be there in the chest wall. The flexor finger is the usual middle finger of the right hand. The action should occur at the wrist level and not at the finger level. And also it is important that you strike with the pad of the finger and not the tip of the finger. It's always important that the percussion occurs from the resonant area or more resonant area to the less resonant areas. Whenever you are delineating the border of an organ, such as heart or the liver, the long axis of the pleximeter finger must be kept parallel to the expected position of that particular border. It is important that the area percus must be more or less equidistant from the two ears, because you need to really hear the thing. It is not just important to hear, but also the feeling is also important. Especially when you get a pleural effusion stony dull, you will find a sensation of pain when you actually tap your finger, especially that pain is perceived in the pleximeter finger. So what are the percussion findings in a patient with pleural effusion? It is the classical dullness that you will get, and is classically described as a stony kind of a dullness. In pneumothorax, you will get a hyperresonant note. But there are other factors of percussion that is important. One is tidal percussion, as depicted in this particular picture. When you percuss in the mid-clavicular line in the anterior chest wall, you will find the lower border of the lung resonance at the beginning of the deep inspiration at a particular point. Let's depict it as point A. Now, once you do a deep inspiration at the end of it, this lower border of the lung resonance actually shifts down to point B. Now, this is in the normal scenario. But if there is a pleural problem, or if there is a subdiaphragmatic abscess or subdiaphragmatic collection, or there is a diaphragmatic paralysis, then obviously this movement does not occur, and this is called as a tidal percussion. Now, another important percussion is the drop space dullness, which is usually appreciated on the left side. Now, what is drop space? It's a semilunar space, which actually the boundaries being the sixth rib at the costochondral junction. This is a vertical line that comes there, and then another vertical line at the anterior axillary line. Now, some textbooks do mention mid-axillary line, but let's look at it. The upper border is actually a line that is actually drawn between the sixth rib as well as the anterior axillary line in that particular direction, and the other one is the costal margin. Now, what are the usual contents? The fundus of the stomach is usually what is there. Now, whenever you get a dullness, you have certain things that is there in your mind. A large pleural effusion, sometimes pericardial effusions, or a full fundus or a fundal growth. That means a fundus with a foot inside, or if there is a fundal growth that is there, or if there is significant splenomegaly, this area might be dull. So tidal percussion and drop space dullness are important, especially when you are actually looking at pleural effusion. So before we go into the auscultatory findings of pleural-based disorders, let's look at where are the auscultatory areas. Now, the auscultatory areas as depicted here are in the anterior chest walls, which is depicted by 1, 2, 3, 4, as well as 7, and the axillary region, which is probably depicted by 5 as well as 6. In the posterior areas, 1, 2 actually denotes the suprascapular area of auscultation, 3, 4, 5, and 6 the interscapular, as well as 7, 8, 9, and 10 being the infrascapular. In pleural effusion, vocal resonance is reduced. I mean, we already looked in palpation and we found that the tactile vocal phomitus is reduced in both pleural effusion and pneumothorax. Vocal resonance is an extension of that, and hence both conditions causes a decrease in vocal resonance. The breath sounds are also reduced or even diminished, and sometimes even absent based on the type of effusion or the extent of effusion, especially if there is a significant accumulation that is there. And added sounds that actually can be picked up, or adventitious sounds that can be picked up in pleural effusion, is a pleural rub, especially in the initial stages of pleurisy. This is basically because of the friction between the two layers, that is the parietal as well as the visceral, the pleura. And what we need to understand that this is usually a leathery or a creaky kind of a sound, which is usually localized and present during both inspiration and expiration. As I said, the vocal resonance and breath sounds are reduced in pleural effusion, but at times above the level of the effusion, you can get a vocal resonance and being increased, as well as an appreciation of a bronchial breath sounds. Now, why does this occur? This occurs because of the partially collapsed lung, which has a patent bronchus. So, to that particular patent bronchus, you will find this bronchial breath sounds and an increase in the vocal resonance. So what are the causes of pleural effusion? There are different ways of actually dividing the causes between common and uncommon, as mentioned here, unilateral as well as bilateral, which is also depicted here. The ones with asterisks are causes of bilateral pleural effusions. The other way is actually to look at whether it's a transudative effusion or an exudative effusion, which we'll come into a little later. So the important common causes includes pneumonia, which is a parapneumonic effusion, tuberculosis, pulmonary embolism and infarction, malignant diseases, cardiac failure, as well as any subdiaphragmatic disorders. Uncommon causes includes hypoproteinemia, which could be because of nephrotic syndrome, liver failure, or malnourishment, connective tissue disorders, post-myocardial infarction syndromes, acute rheumatic fever, myxedema, uremia, and even asbestos-related both benign disorders of the pleura as well as even mesotheliomas. So one of the most important investigations is a chest radiograph, and it is very important for you all because I think this can be actually kept as a spotter or even asked during the radiological examination during the Viva voice. So one of the important things that you can see is a significant homogeneous opacification that is there in the right lower zone. So non-homogeneous opacity can be a consolidation, whereas homogeneous opacity, especially like this, is usually seen in a pleural effusion. You can also see that the right costophrenic angle is obliterated, and also a radiological illusion. That means there is a finding that the fluid is actually being tracked up to the axilla. This is has been called as the Ellis S-shaped curve. This sometimes has been mentioned in books as a radiological illusion. Sometimes they say that it is because of the capillary suction that is there, which actually causes this kind of a picture. So once you've done with your confirmation of the diagnosis by an X-ray, you should actually take the fluid out and send for analysis. One of the most important requirement is to actually figure out whether it is a exudative or a transudative kind of an effusion. Exudate is if likely one or more of the following criteria are met. So what are the criteria that are taken into consideration? If the pleural fluid protein to serum protein ratio is more than 0.5, or if pleural fluid LDH to serum LDH ratio is more than 0.6, or if the pleural fluid LDH is more than 2/3 of the upper limit of the normal serum LDH. Now, only one criteria is required to actually confirm whether this is a exudative pleural effusion. Now let's look at the etiology of transudative versus exudative pleural effusions. Most of the transudative ones are actually simple. It's either heart failure or cirrhosis or nephrotic syndrome or significant hyperproteinemia because of other reasons. It can also be seen in actually myxedema and other situations like peritoneal dialysis. Exudative pleural effusions are all infective pleural effusions, pleural effusions associated with malignancies as well as connective tissue disorders. Drug reactions as well as post-myocardial injury also comes under exudative pleural effusion. A noteworthy thing is that all the other organ failures causes a transudative pleural effusion except for uremia. Uremia actually causes an exudative pleural effusion. Another important thing is pulmonary embolism can actually be either transudative or exudative or even blood tinged fluids. I mean, there are other attributes of the pleural fluid which is important to make a final diagnosis. Like the color and texture of the fluid. You might have figured out that it's an exudative pleural effusion, but you should know the exact diagnosis to actually treat this particular patient. As in what causes this exudative kind of a pleural effusion. So these are some of the important aids that we can use. The color and texture, if it is a pus that is obvious there, then it is an empyema. If there is a chylous fluid that is there, then obviously it is a chylothorax. So obviously it is important to have a macroscopic appearance at the pleural fluid after you actually tap it out. If there is blood that is present, it could be actually a part of pulmonary embolism or infarction, can be actually seen with malignancies and even sometimes when you have a traumatic kind of a tap. Gram stain may suggest a parapneumonic effusion. Sometimes also AFB stains are employed. Not always you get an AFB stain being positive in a patient with tubercular pleural effusion, because tubercular pleural effusion is actually because of a hypersensitivity and that causes kind of an inflammation and fluid there. And you might not get an AFB stain, but occasionally we have found AFB stain in pleural fluid as well. The predominant cell type, whether it's neutrophilic predominant or if it is lymphocyte predominant, can be used for differentiation between tuberculosis as well as bacteria, pleural effusions. Gene expert is an extra aid which actually can tell you whether it is a tubercular pleural effusion. ADI is another useful tool which actually will tell you if it is a tubercular pleural effusion. ADI being elevated suggests that it's a tubercular pleural effusion. Cytological examination is very important, especially when you are suspecting a malignant effusion. The pH of the pleural fluid is also to be estimated, and if there is a low pH, it suggests that there is a complicated parapneumonic effusion, which suggests a significant infection or a rheumatoid arthritis, and in rare scenarios even a ruptured esophagus. An important type of pleural effusion is empyema, that is when you find pus in the pleural cavity. The systemic features include high-grade fever, which is usually remittent. Patients will have rigors, sweating, malaise, and even weight loss if it is actually predominantly present over a significant period of time. Patient will even have a polymorphonuclear leukocytosis as well as an elevation in the inflammatory markers like C-reactive protein. Pleural pain is present as in like a pleural effusion, but it is much more severe. Sometimes there is even intercostal tenderness that you actually find. Some patients will have cough and sputum production. Usual pleural effusion is usually a dry cough. Here there could be sputum production because of the underlying lung disease. And there could be copious purulent sputum if the empyema ruptures into a bronchus, which actually is called as a bronchopleural fistula. The clinical signs of pleural effusion are the same as in empyema as well, but one of the important general examination findings is actually clubbing, and one of the important systemic findings is actually intercostal tenderness. I think it's very important and it's very easy to diagnose if the fluid is thick and you actually can get macroscopic pus. There is no difficulty in confirming empyema. But in certain other situations, I think a complicated parapneumonic effusion or some similar to empyema have to be suspected if the fluid glucose is actually less than 60 milligram per deciliter, or the lactase hydrogenase value of the pleural fluid is more than 1000, and the pH of the fluid is actually less than 7. In such scenarios, these patients might require not just aspiration but an intercostal drainage tube. We already discussed the definition of pneumothorax, that is when air is found in the pleural cavity. Uh, there are three important types. One is the primary and secondary, which actually comes under spontaneous, and the next one is the traumatic one. So the primary is actually in a patient who do not have a overt lung disease. So the air escapes from the lung into the pleural space through a rupture of a small pleural bulb or the pulmonary end of a pleural adhesion. Whereas in secondary, there is an underlying lung disease. This is mostly a chronic obstructive pulmonary disease, which can cause an emphysematous bullae, and that bullae can actually rupture. Sometimes tuberculosis can also be seen. Rarely also asthma, lung abscess, and pulmonary infarcts, and even lung cancers all form this kind of a secondary cause for a pneumothorax. Traumatic being either an iatrogenic following a thoracic surgery or a biopsy, or sometimes after a road traffic accident or any other kind of a chest wall injury. It is also important to understand the types of pneumothorax. Two predominant ones are the closed one and the open type. Okay, so in the closed type, the communication between the airway and the pleural space seals off as the lung deflates, and it usually does not reopen. In such scenarios, spontaneous reabsorption of the air and re-expansion of the lung occur over a few days or weeks. Infection risk is actually very low in such patients with a closed type. Whereas in an open type, the communication fails to seal and the air continues to pass freely between the bronchial tree as well as the pleural space, like a bronchopleural fistula. The spontaneous reabsorption of the is actually unlikely, and the infection risk is actually very high, and patients can actually predispose to form empyema. In the tension type, which I said is emergency, the communication between the airway and the pleural space usually acts like a one-way valve. That means it allows air to enter the pleural space during inspiration but do not escape on expiration. So spontaneous reabsorption of the air and re-expansion of the lung usually does not occur, and compression of the opposite normal structures and impairment of the systemic venous return causes significant cardiovascular compromise in the form of tachycardia as well as hypertension. And this has to be treated like a emergency, and measures have to be taken to relieve this pressure. That is, the most important things to be done is an emergency intracostal drainage tube. If that is not possible, you have to actually do a needle thoracostomy and through the second intercostal space and relieve the pressures. I want to once again stress upon the important clinical manifestations of a tension pneumothorax. It is rapidly progressive breathlessness. It is one of the important causes of an acute dyspnea. Patient will have marked tachycardia as well as hypertension. There will be cyanosis revealing a type 1 respiratory failure. There is tracheal displacement away from the side of the silent hemithorax, which shows that the mediastinum is actually shifted. But occasionally in tension pneumothorax, the mediastinal shift might not be there, especially if there is a malignant process that is happening on that particular slide. So it is very important that the Indian medical graduate knows how to actually pick it up with a usual chest X-ray or a radiograph. So you can see the expansion of the lungs on the or the hemithorax on the left side, and you can see that the lung markings are actually not there. There is significant translucency that is actually seen on the left side. Okay, and there is also a sharply defined edge of the deflated lung that you can actually see here, which is not so well appreciated here. The extent of the mediastinal displacement, it basically depends on the type of the pneumothorax here. And you can see that the trachea, which is here, is actually significantly shifted to the opposite side. For completion's sake, it is important to even actually mention about hydropneumothorax. I think one of the classical X-ray picture is this, where you find a fluid level. You can see the horizontal fluid level with the obliteration of the cardiophrenic as well as costophrenic angle, suggesting that there is significant amount of fluid there. And at the same time, you can actually find here a significant amount of translucency which is there with no lung markings, and this suggests a hydropneumothorax. One of the most common etiologies of hydropneumothorax is actually an iatrogenic one or a traumatic one. Some clinical examination methodologies of predominantly historical importance in hydropneumothorax include shifting dullness, straight line dullness, succussion splash, as well as coin sound. I don't think these are done nowadays because there are more effective ways in which we can actually find out if there is a hydropneumothorax, as actually depicted by X-ray or other modalities of imaging. But however, for the perspective of this being a clinical class, I would like to tell you how a shifting dullness works. So a shifting dullness is actually demonstrated where the maximum point of dullness is actually found in the axilla in the sitting position, and then the patient is asked to lie down on the unaffected side, and then when you actually percuss, you'll figure out that that area has become resonant. Similarly, the straight line dullness as well as succussion splash is actually a crude method where actually the splashing sound is found when you actually shake the patient vigorously on the non-dependent area of the shoulder, and obviously keep the stethoscope. Coin sound is a metallic sound you find when actually a stethoscope is placed at the level of the fluid on the opposite side, and you keep a small coin there and make a striking with another coin on top of that particular coin. You will find a metallic sound from the stethoscope on the diametrically opposite side. So these have been crude methodologies which have been there, which was required at a particular time to make a diagnosis, especially in the past when imaging modalities were not so good. But it is important that we know some of them for the completion's sake. So whatever it is, whether it is a pneumothorax which is actually significant, or if it's a tension pneumothorax or a hydropneumothorax, the main way in which you actually relieve this is actually by inserting a ICD. So I think with this, I come to the end of this short clinical discussion. Hope you've benefited from this. All the best for your exams. Thank you.